All right, so we can start with the today's session as a part of this integrated MCQ. Today we are going to discuss cardiovascular system, and in cardiovascular system we will be going to discuss a very important condition, and that is one of the frequently asked questions from that topic. So let's start with the clinical history. Moving on to this clinical case. So in this clinical case, we will be discussing how to approach clinical information, how to make a differential diagnosis, and how to come to a conclusion. So question is 25-year-old male present with complaints of dyspnea for the last 2 to 3 months. He also has lightheadedness on doing a brisk walk. Now, on examination, these are the findings which are given to you. So one by one, let's dissect this question. So here, on examination, pulse is Bispherians. So Bispherians pulse, all of you know, it has a few differential diagnoses. So Bispherians pulse is seen in cases of severe aortic regurgitation, severe AR. It is also seen in severe aortic regurgitation along with aortic stenosis, but the predominant lesion should be a severe AR. While the third condition is HOCM. Now, the JVP given as raised. So the raised JVP can be seen in all these conditions, especially if the right side is getting affected. So JVP raised will be a feature of the right-sided involvement. So because of late cases or extreme cases of aortic regurgitation, there can be a right ventricle failure also, because the most common cause of the right ventricle failure is left ventricle failure. And as well as in HOCM, the JVP can be raised, and JVP is raised in cases of HOCM because of a phenomena, and that phenomena is known as a Bernheim's effect. Bernheim's effect. So what is Bernheim's effect? Bernheim's effect is the septum, the interventricular septum. It bulge into the right ventricle if it is hypertrophied septum, and if right ventricle bulging occur, then right atrial pressure increase, JVP increase. So this is the meaning of a Bernheim's effect: hypertrophied septum compressing the right ventricle. Yes, very good. Abhishek has given it the correct answer, Bernheim's effect. Now, the apex beat is given as a double apex beat, which can be seen in cases of aortic stenosis or which can be seen in cases of HOCM. The third differential diagnosis of a double apex beat is left ventricle aneurysms. Left ventricle aneurysms. So this apex will give us a clue key out of these the possibility of AS can be there, HOCM can be there, or a left ventricle aneurysm can be there. Now the auscultatory finding shows that there is a S1 being soft. So S1 being soft is a non-specific finding. It can be seen in almost any valvular lesions. So this has a huge differential diagnosis. It can be seen in aortic stenosis, it can be seen in aortic regurgitation, it can be seen in mitral regurgitation. So lots of differential diagnosis of a soft S1. While S2 is reverse split. S2 is reverse split means that this A2 is late, it is going beyond the P2, and this has a differential diagnosis of aortic stenosis. It can be seen in cases of HOCM. Reverse split can be seen in cases of left bundle branch block, left ventricle failure. So these leads to a reverse S2 split. Reverse S2 split. While S4 left ventricle side S4 is present, that means we are dealing with a case of left ventricle hypertrophy due to stiffness. Now, left ventricle hypertrophy again can be because of aortic stenosis. It can be because of HOCM. It can be because of systemic hypertension. So, these are the differential diagnosis of the clinical finding which we can get. Now, comes the most important examination finding, which is the murmur. So, if you identify a particular murmur, what is the type of the murmur and which area it is heard, so the diagnosis become more or less clear. There will be a very few diagnoses or maybe a single diagnosis. So ejection systolic murmur is present, and it is present as the left third intercostal space. So this ejection systolic murmur, okay. Harshit, the double apex in aortic stenosis occur because of the septal hypertrophy. So septal hypertrophy in aortic stenosis can lead to a double apex if septum is hypertrophic. Now, this question is to all of you. Ejection systolic murmur at the third left intercostal space. What differential diagnosis can you make? Remember, it is on the left third intercostal space that you are finding a ejection systolic murmur at the left third space. Yes. So what will you think of the differential diagnosis? Because ejection systolic murmur have few causes. In terms of valvular regions, it has few causes. It can be pulmonary stenosis. It can be ejection systolic murmur, can be aortic stenosis, can be HOCM. TIA, no. Tricuspid regurgitation is a pansystolic murmur. HOCM, yes, one cause is HOCM, ejection systolic murmur. Other cause can be aortic stenosis or pulmonary stenosis. Yes, that can be the differential diagnosis. AS, yes, and PS. And of course, high cardiac output states can produce a ejection systolic murmur. But the most important point here is the space. So remember, the pulmonary stenosis is seen in pulmonary area. And where exactly is the pulmonary area? It is the left of the sternum. So it can be an important differential diagnosis. It is a second left intercostal space. While aortic stenosis, it is heard over the right second intercostal space. So this is slightly unlikely. AS is unlikely because it is found on the right side. So PS can be an important differential diagnosis. It is found over the second left intercostal. HOCM. HOCM is found over the third left intercostal space, third or fourth left intercostal space. So this can be a diagnosis here. This can be a diagnosis here. So if we match all these findings, so in all these findings, the HOCM was a common finding of Bispherians, JVP raised, apex double beat. Pulmonary stenosis is not associated with any Bispherians pulse or the other findings which we have seen here. So out of this, pulmonary stenosis and HOCM, it goes more in favor of HOCM. It goes more in favor of HOCM. So what will be your answers now? So out of these choices, what is the likely cause here? So the likely cause here is most likely, I will not say with confirmation, most likely it will be a case of, yes. What will be your answer out of the options given to you? So pulmonary stenosis is not given in the options. So the answer here will be, yes, it will be HOCM. So answer is most likely it will be a HOCM pathology. Yes, B will be the most likely answer. Most likely answer. Hypertrophic obstructive cardiomyopathy. Now, this hypertrophic obstructive cardiomyopathy is a FAQ, frequently asked question. And in this, you are given the images or maybe the cadaver heart is given to you of HOCM, recently asked, last year it was asked. indeed, every year there is a one question on the HOCM which is coming. So now I will hand over to Dr. Sanjeev to put some light on the pathophysiology of this HOCM, and then we will proceed for other clinical feature, how to make a diagnosis of HOCM, and then the treatment of HOCM. So Dr. Sanjeev, I am unsharing my screen, so now you can tell us all about the pathology of HOCM.
Thank you, Arvind sir. Thank you very much. And when I saw them, all the close differentials that you are discussing, dear students, once you understand the pathology, many of your differential diagnosis and also many of the queries that I am seeing here, will end up, they become more easier for you. I hope all of you are able to see me and also able to hear me now. Okay, so as Sir said, most likely diagnosis, the provisional clinical diagnosis was your HOCM in this. Let us first understand HOCM, and very close DD was your aortic stenosis as well. And of course, pulmonary also, sir discussed. Okay, let me first start with this HOCM. What is HOCM? Once we understand this, then we will understand a lot about, other diseases as well here. So hypertrophic obstructive cardiomyopathy, that is the name, HOCM, or just can call it as HCM as well, hypertrophic cardiomyopathy. The obstruction part that is there, that's the functional obstruction. We will discuss that part as well, right? Let us talk about, so what mutations are causing HCM or HOCM. Most common mutation is, it's a genetic disease by the way, so most common mutation that is causing this disease is MYH7, myosin heavy chain 7 mutation. So these are all facts, can come as a question in your exam. Myosin heavy chain, will focus more on pathogenesis in this integrated part. Then other than that, even MYBPC mutation can be there. Myosin binding protein C mutation. Very rarely you can get troponin mutations and also the troponin I and troponin T mutations as well. There are many more mutations not required to know at your level. Now, so we are talking about the pathogenesis next. So I want to discuss, okay, before that, what is the inheritance? That is the next important question. Inheritance of this condition will be autosomal dominant in inheritance. So it's an autosomal dominant condition. And importance of all autosomal dominant diseases. Remember, if it is an autosomal recessive condition, then you have to check for the partner always. If patient is having autosomal recessive, either is a carrier or he's having a disease, you have to check the partner. But in autosomal dominant condition, somebody has an autosomal dominant disease, then you have to always check the siblings and the first degree relatives. Always remember these two facts, just in general, anywhere. Autosomal recessive disease or a carrier, check partner, because next generation can have disease. Autosomal dominant disease, carriers are not there in autosomal dominant. You always have to check your first degree relatives. Siblings and parents have to be tested, right? Yes, that is the first degree screening is mandatory. First degree relatives will be mandatory. So let us talk about the pathogenesis here. So pathogenesis of this disease, what exactly happens in pathogenesis of this condition? So in pathogenesis, there is hypertrophy. Name itself is telling there will be hypertrophy happening, isn't it? Hypertrophy is happening, and hypertrophy, yes, hypertrophy of myocardium will be happening. So there will be hypertrophy of myocardium, and this is asymmetrical hypertrophy usually. So when I say asymmetrical, it will not happen equally everywhere. This will be more in the septum. In the interventricular septum will be more hypertrophied here. That is what is the main pathogenesis. Now, let me try to explain this pathogenesis with the help of rough diagram of your heart here. Let me try to draw one normal heart. So I'm showing only the ventricle here because we are interested in ventricle. So this is your left side and the right side and the interventricular septum that I'm drawing, right? So right ventricle, the left ventricle. This is your normal heart I'm trying to show. And this is your aorta which is coming out of the left ventricle here, right? Yes. Now, and also there will be a valve. So this will be your AV valve, the left-sided AV valve, the mitral valve will be there. And this part, now important to note, the A is aorta here, and I'm labeling one more with the purple arrow. So this is a part, a narrow area where the blood from the left ventricle will be entering into your aorta. This part we call it as a left ventricular outflow tract. So basically, when the ventricle goes into systole, the blood enters in through this LVOT. It is not it is not like an artery or any vessel. It is just a part of your chamber of the heart where it directs towards your aorta. That's it. So this is your left ventricular outflow tract. Now, so let us look what exactly happens in this condition when hypertrophy. This is the normal heart. Now, when hypertrophy happens, now we can understand there will be increase in thickness of the septum we discussed. So look at the septum. The septum has become very much hypertrophied. Septum has become very much hypertrophied, and even the wall will also be hypertrophied. So I am showing the wall. Wall is also what? Hypertrophied here. Septum is. So now look at this. Septum is more hypertrophied. That is what I am showing you. Now, because of this, yes, now we can understand. So, all your clinical features of double apex bait and all those things are happening because of this finding here. Now, let us look what will further happen here. Now, because the septum has become hypertrophied and your ventricle has become more thinned out. Now, two important things are happening because of this pathophysiologically. So what is this part? This was your what? Left ventricular outflow tract. Now this your hypertrophied septum is, obstructing your outflow tract here, right? This is your obstruction that is happening. Now very important obstruction here is, it is infravalvular obstruction. And this obstruction, LVOT, is getting obstructed here, right? So aortic stenosis also will create similar murmurs I was telling you already, and aortic stenosis also, by the way, can end up leading to concentric hypertrophy as well. So which will end up again similar findings will be there, double apex beta, etc. Now only difference is here the obstruction is subvalvular. We'll discuss some more points about that obstruction subsequently. Now one more thing is happening is because of this the ventricular cavity size is reducing, right? The ventricular cavity is reducing. So that means what? If the cavity is reducing, that means the volume of the ventricle is reducing. Remember this, there's a volume of ventricle reducing. Similar things happen even in what? The concentric hypertrophy secondary to what? The aortic stenosis, isn't it? Yes. So now let us understand further what exactly will be the pathogenesis because of this. So if you have understood this, what exactly is happening, this will give you a lot of idea. Before going further for pathogenesis, I'll just show you your actual image of HOCM. So now look at this. This is your actual image of HOCM. This is your ventricular wall, the left ventricular wall. This is the left ventricular cavity, and this is your interventricular septum. So interventricular septum has bulged here, and because of that, there is a narrowing of your left ventricle happening, isn't it? And also you can see this is your left ventricular outflow tract. This will be your aorta, by the way. So this is your left ventricular outflow tract. So your blood has to, it is like a not bypass, it is a long route that you are taking. The blood is taking a longer route here. There is a narrowing of the outflow tract happening, isn't it? Now, let us further understand a little bit more what exactly is hypertrophy leading to. So I want to discuss what exactly the hypertrophy leads to here. We understood there are two changes happening in the anatomy of the ventricle. The ventricular cavity is reduced and there is a outflow tract is obstructed. So two anatomical things are happening. One is LVOT obstruction, left ventricular outflow tract obstruction. We can call it more of a functional obstruction because your interventricular septum is not fixed. It can still move based on the amount of blood. If there is more blood in your left ventricle, it can push the interventricular septum away from the obstruction. So thereby relieving the obstruction basically. So now because of this obstruction, what will happen? Two things will happen because of obstruction. If there is an obstruction, there will be reduced outflow from the left ventricle to the aorta. Although your ventricle has a capacity to pump more because of this hypertrophy, there will be less cardiac output happening. Although this is not the most important reason why cardiac output reduces, but however, some amount of reduced cardiac output is because of your left ventricular outflow tract obstruction here. Now, Once, then also this will create a murmur. Yes, and the murmur, the patient is also having an ejection systolic murmur, because when the blood passes through this obstruction, the narrowed area, that will be during the systole, and you will end up seeing this murmur as we already discussed in this patient. So there is a murmur that is happening. Now I told you this obstruction, we call it functional or a dynamic obstruction, we call it. It's not a fixed obstruction like your aortic stenosis or any other valvular diseases, where there is what, every time there is an obstruction because there's a pathogenesis. Here this is a dynamic obstruction, we call it, or maybe a functional, better word, any word you can use. So because of this dynamic, as I just told you, if you fill, now look at this, if you fill more blood inside the ventricle, then what happens? If you try to fill more blood inside the ventricle, it just pushes your interventricular septum away. Because it pushes the interventricular septum away, your obstruction gets relieved. If there is less filling of the ventricle, then nobody is pushing this away. That is why your obstruction can get what? Worsened as well. So this is your dynamic obstruction. It depends upon what exactly, how much you are filling the blood in the ventricle, right? That is very, very important to understand. And the importance of this also, many of you were wondering probably that, how do I differentiate this from aortic stenosis? Sir already discussed one, and he will be discussing further also, how to approach that. So very important is the obstruction will worsen. When the obstruction worsens, because worsening of obstruction means your murmur intensity can increase. Not only murmur intensity can increase, cardiac output can what? Further reduce, causing more problem to the patient. So obstruction will worsen with reduction in ventricular filling. So basically, ventricular filling in the ventricle is nothing but your, during diastole, we call it the preload of the heart. So basically, if your ventricular filling, that is, venous return to the heart, reduces, then obstruction will worsen. If ventricular filling increases, the obstruction automatically get relieved here. So that is the importance, and the applications I will be discussing subsequently about the clinical application of this fact. So this is about the one part. The anatomical part is obstruction. Another anatomical part was reduction in ventricular cavity we discussed. So if the ventricular cavity reduces, then what will happen? Ventricular cavity reduces, that means there is less space to fill. So if there is less space to fill, you cannot fill more. So there is reduced filling of the ventricle. So filling of the ventricle is reduced. This is what we call it as what? Diastolic dysfunction or diastolic failure of the heart. So basically, heart is unable to perform well in diastole. Basically, filling is less reduced. Now, if the filling gets reduced, obviously, if there is less filling, your heart cannot pump more blood. Whatever it has filled, only it can pump that much. So basically, this will also add up to your reduced cardiac output. In fact, most important reason why cardiac output reduces is because filling is reduced. Filling is already reduced, and further there is some amount of obstruction. Although obstruction is not the most important, I told you filling is reduced. Now my next question is the third part that we will discuss, that is your not anatomical part, that is a physiological aspect of this disease. So the anatomical aspects were two, obstruction and a reduction in the ventricular cavity size. The third one is the physiological. Whenever there is a hypertrophy happening, or pathological, you can say either of it, when hypertrophy happens, simple understanding, force of contraction of the heart increases. So there is an increase in force of contraction of the heart. So if hypertrophy is leading to increased force of contraction, then what will happen? Increase in force of contraction, we all understand, will end up demanding more. Yes, increased force of contraction means increased demand by the muscle. The myocardium is demanding more, whereas your supply, we discussed already, the cardiac output is reduced, so your supply is already reduced. So there is a reduced supply and there is an increased demand happening. And this is what we call pathophysiologically, there is a demand supply mismatch happening. So there is a demand supply mismatch in the patient already existing. So the disease itself is causing what? Demand supply mismatch. So if your demand supply mismatch is there, we all understood it can be causing, acutely it might cause a angina. If it becomes more severe demand supply mismatch, it can even cause a myocardial infarction, or on a long standing, it can lead to heart failure. Of course, there will be heart failure happening. Why? Because heart is getting less blood and it is demanding more blood. So your myocardium cannot function. Although it is hypertrophied, eventually it cannot function for a reason, because the heart is demanding more, but you are supplying less blood to the heart. So although it is hypertrophied muscle, it doesn't get enough oxygen, it cannot pump. So although it is hypertrophied, it cannot pump eventually. So there can be heart failure. Sudden can be angina or MI, and even what? Heart failure can be happening in this on a long standing. And that is why left-sided failure, and then that would have led to your right-sided as well, as was there in this patient as well. So don't confuse. Although there is hypertrophy, there can be one heart failure. Heart is unable to pump the blood, which will further reduce your cardiac output, which will worsen. It's a vicious cycle after that, right? Now, so very important here we need to understand is this demand supply mismatch. So what is the importance of this demand supply mismatch? Pathologically, we need to understand what factors will precipitate this mismatch. Demand supply mismatch is worsened or precipitated, either of the word you use, is worsened when. So demand supply mismatch will worsen if supply reduces or demand increases, or both of them happen simultaneously. Yes, so it can happen if filling reduces. Filling reduces means what? Supply reduces. Basically, filling reduces. What is filling reduced? Means reduction in preload. Simple. So filling of the heart is reduced. Then the supply reduces. Demand doesn't increase because of this, but the supply reduces. Or there is an increased demand. Demand increases. So when will demand increase? Whenever there is a force of contraction of the heart increases. So very, very important. Anything that worsens demand supply mismatch can cause angina, MI suddenly, right? Acute condition. Heart failure anyway will keep happening over span of time. Angina, MI can happen if there is a sudden demand supply mismatch worsening, like filling reduction. When will filling reduce? Many things will reduce filling, like vasodilators, diuretics can reduce. Then there can also be Valsalva maneuver that can reduce. Valsalva maneuver commonly is done during straining of stools. If you remember, it is nothing but forced expiration against the closed glottis. During expiration, venous return will reduce ultimately. Then other than that, there can be even diuretics will also reduce your filling. Diuretics will also reduce your filling. Even exercise also reduces filling. Now, sir, how does exercise reduce filling? Remember, cardiovascular effects on exercise will be two things. One, there will be increased rate of contraction. Just a minute. Yeah. So there will be increased rate of contraction. That's the first thing will happen. Increased rate of contraction is nothing but your what? Tachycardia will happen, right? Tachycardia will be happening. Sorry. So there will be, so tachycardia, when tachycardia happens, then the diastolic period reduces. If you remember, diastole reduces, filling time will be less. So that is why filling will be reduced. Second one is, if the demand increases, there can be increase in demand also happening, which will worsen the demand supply mismatch. So demand increases commonly during exercise. Even other drugs like inotropes also can increase the demand. We usually do not do there, but anyway, exercise is the one where force of contraction increases. Now look at this. Exercise is creating double problem to this patient. What problem is exercise creating to this patient? Exercise is increasing demand and also reducing filling. So filling is reduced and demand is increased. That is why strenuous exercise will precipitate angina, MI, even sudden cardiac death. That is why one word they will be giving you. This is one of the most common cause of sudden cardiac death. Sudden cardiac death in young athletes. So very, very important, sir. Why it happens only in young athletes? Why not others? No, it doesn't happen in young athletes. It happens in any young person. Death happens in athletes. See, it is an autosomal dominant condition. It will happen in young patient only because it will be right from birth only. It will be there. So death will happen in young, and it will be in athletes because athletes are the one who will end up what? Doing a lot of strenuous exercise, which will end up causing both problem here. That is, your reduced filling will happen and increased demand can happen, isn't it? Yes. So this is all about the pathogenesis of your the hypertrophic cardiomyopathy. Just to tell you, in aortic stenosis, in aortic stenosis, the obstruction that will be there will be what? Fixed obstruction. That is, the aorta is the problem. It will not, the obstruction cannot get relieved by your increase in filling or reduced in filling. Only thing is, more filling means more blood has to pass through the aorta. But otherwise, obstruction will not change with filling of the ventricle, which will not be a dynamic obstruction like HCM. And I think further, Dr. Arvind sir will take all the rest of the aspects of how to approach patient and the treatment part. So over to you, sir, Arvind sir. Back.
Thank you, Dr. Sanjeev, for such a presentation in a very simplified manner and covering all the aspects of pathophysiology. And if we understand the pathophysiology, we can easily look into the clinical aspects of the HOCM, especially the murmur. So coming back to our patient, the likely cause here is HOCM. Now, this murmur, which was an ejection systolic murmur at the third intercostal space, why it is because of the HOCM that we can further prove with the help of some maneuvers. So this HOCM murmur is unique, as Dr. Sanjeev has explained. Whenever blood flow is reduced in the ventricle cavity, murmur will increase. While rest of the valvular disease, leaving aside the MVP, they behave in a manner that when you increase the blood flow, the murmur will increase. While HOCM, when you increase the blood flow, the murmur will reduce, and vice versa. So this murmur will be behaving differently. So the question is, which maneuver will increase this murmur if we are suspecting it a case of HOCM? So those maneuvers where blood flow into left ventricle is reducing. So that will be the maneuver where the blood flow into the left ventricle is reduced. Yes, the answer is standing, sweating. So I'm getting a mixed response. So let's see one by one. Expiratory phase. So the expiratory phase, what it will do, a normal expiratory phase, it squeezes the pulmonary vessels and that blood will go into the left ventricle. So it increases LV blood while squatting. So whenever we are talking about the squatting, you assume it as an immediate effect of the squatting. Immediate of the effect of the squatting is it is compressing the inferior vena cava and giving the more blood to the heart. So always assume it to be the immediate effect of the squatting, and immediate effect is increases the left ventricle blood return into the heart. While standing, obviously standing position means to decrease venous return to the heart, so decrease LV blood. Now coming to the sustained hand grip. So what exactly is a sustained hand grip? Sustained hand grip is, in a sense, is increasing the aorta pressures. Aorta pressures. So the gradient here will be left ventricle pressure minus aorta pressure. That will be the gradient of the HOCM here. So what will happen if the aorta pressure is increasing? So this gradient will reduce, and any murmur where the pressure gradient is reducing, every murmur without any exception reduces. So if the gradient is reducing, why gradient is reducing? Because the aorta pressure is increasing. So we apply a simple mathematics here. LV pressures minus aorta pressure increase, the difference will reduce. And if the gradient reduce, murmur will reduce. So here the answer will be the standing position. So this also proves that in a standing position, if the murmur is increasing, no other murmur will be behaving in a similar fashion. Also, important point like Dr. Sanjeev has raised, it has to be differentiated from the murmur of valvular aortic stenosis. So how to differentiate a murmur of HOCM from the aortic, valvular aortic stenosis? So the important points here are valvular AS versus the HOCM in terms of murmur. So murmur is same, ejection systolic. The site is different. The valvular AS is a right second intercostal space, which is the aortic area. HOCM is a left third or fourth intercostal space. Then the radiation. So the valvular AS murmur usually radiate to the carotids above. So it is neck. While HOCM murmur, there is no radiation. It does not radiate. It remains inside the ventricle cavity. While the maneuver, so the maneuver which increases the valvular AS, expiratory phase, squatting. These maneuvers will increase the murmur of valvular AS, while they decrease the murmur of HOCM. So, like that, we can clinically differentiate between these two murmurs, valvular aortic stenosis and HOCM clinically. Now, moving on to the next aspect that we are doing the clinical aspect, but how the investigations will prove. So, if we go to the investigations, so in the investigations, we have ECG and we have echocardiography. So in the ECG, you will get the voltage criteria for LVH voltage criteria. And LVH voltage criteria is in V5 or V6. The R wave height will be more than 25 mm. If a single ECG lead is given to you. So there are other criteria also, but this is a simple criteria. And the second one is because of the severe ischemia of the inner zones of the ventricles, we will get a ischemia-like change, a strain pattern we will get, and that is typically a giant inverted T waves. And that is mainly seen in cases of a apical hypertrophy, a variant apical hypertrophy is there. So there will be a giantly inverted T wave. Giantly inverted T wave means the depth of the T wave is more than 10 mm depth of the T wave. So these features will support a diagnosis of the HOCM. But though these changes can also be seen in a valvular AS or a severe hypertension, so when we look at the echocardiography, so the recently accepted criteria in the echocardiography is the ratio. So we take the ratio of the thickness of the septum and the posterior wall. So if the septum thickness divided by the posterior wall thickness, if this ratio is coming to more than 1.3 in a normotensive individual, this is the diagnostic criteria. So this will clinch the diagnosis in favor of HOCM. Though other typical features like banana-shaped LV cavity can also be seen. Banana-shaped LV cavity. But sometimes it will not be so sensitive or specific to make the diagnosis. So we rely on the ratio. So with that, we come to the conclusion that it is a case of a HOCM. Now, these are the echo finding and ECG finding in our patient. Now the patient will come to you with the reports. You have made a diagnosis of HOCM. So the question to you is, what will be the next line of management in this patient? What will you do? in this patient? So your answer, yes. What will be your answer? Will you give a beta blocker? Will you give amiodarone or calcium channel blockers or implantable cardioverter defibrillator device? So I'm getting the answer as beta blocker. All right. So will you give beta blocker, amiodarone, or ICD? So remember, beta blocker is the initial drug of choice by decreasing the contractions, by decreasing the contractility. It decreases the systolic anterior movement of mitral valve, and it decreases the obstruction which is happening here. So it is the initial drug of choice. While if beta blocker is contraindicated, then we give CCB. Like if a patient has got a bronchial asthma where beta blocker cannot be given, then go for a CCB, and those CCB which are decreasing the contractility of the heart, like the non-dihydropyridine group, will be given here. Now coming to when will you give the amiodarone and when will you put the patient on ICD device? So the important question which is asked on the implantable cardioverter device. So there should be some indication, and read the question very carefully. If in the question there is some indication which is coming, so will our option will change or not? So indication is number one. Indication: if patient is a survival of cardiac arrest in the past, cardiac arrest, or sustained ventricular tachycardia history, documented history. So it is the indication, straight away indication, or any two of following, any two of the following. So the first is sufficient to make a diagnosis and to make an indication of the ICD. While the other indication for the ICD is two of the following features. These features are: number one, syncope. Remember, our patient was complaining of syncope during lightheadedness symptoms, so during the exertion. So syncope episodes. Number two, family history of sudden cardiac death. Number three, if patient develop low blood pressure during exercise, during treadmill. Number four, if the left ventricle wall thickness more than 30 mm. And number five is if patient has a non-sustained ventricular tachycardia documented. So we need two of the following criteria for a case of ICD. And if patient has a past history of cardiac arrest or sustained VTAC, then straight away implantable cardioverter defibrillator device will be given. And if patient refuse ICD, patient say that I can't afford the ICD, then you give amiodarone. Amiodarone has been shown to decrease the risk of sudden cardiac death. So if we go to the clinical history once again, so let's see whether our answer change or not. Patient has dyspnea, lightheadedness on doing a brisk walk, and these are the findings given to you. So that means the criteria for ICD device, indication for the ICD device is not present in our patient. So therefore, our answer will remain the beta blocker. Therefore, read the question very carefully. Though in this question you have given it correctly, beta blocker, but read the question carefully whether there are any indication for the ICD present or not. Then you will put the patient on the ICD. That will be the best therapy in our patients. So this was the clinical case in the form of MCQ of HOCM. Now we will be very happy if you put up your questions in the chat box. We'll try to answer your questions. Yes, students, your question for the this clinical case of HOCM.
Yeah, students, I hope all of you have got a very good glimpse of the integrated learning, and really, it's so nice to go back into the final year or PG entrance preparation for me, especially such an integrated class with Arvind sir.
Same here, Dr. Sanjeev. It's very nice to go into the pathology. I would say into the second prof, because pathology is such a wonderful topic. Without pathology, we can't become a clinician. So this is a very important topic. Question is, what does the SAM stands for? So the SAM stand for a systolic anterior movement of the mitral valve towards the septum. So this increases the obstruction further. Alright. So the ratio is taken of the septum versus the posterior wall in a normotensive patient. So that if more than 1.3 is a diagnostic criteria. 1.3. Yes. Double apex was in context to JVP wave. No. Double apex was in relation to palpation finding. JVP was raised because sometimes the septum hypertrophy can bulge into the right ventricle also. So right ventricle pressure increase, right atrial pressure increase, JVP will increase. So the double apex was in relation to the palpation. All right, so we can wind up the session here, Dr. Sanjeev. And
yes,
we express all our thanks to the students who have joined this session, and all the very best for your exams.
Yeah, so best wishes for all of you.
All right, so good night, everyone.
Yeah, good night everybody.